Thank you all for joining this fireside chat today. This is part 2 in a series of 2 focused on children and youth with special healthcare needs and children with medical complexity. And the title of the series is Awareness and Preparedness. Today's fireside chat will focus on disaster planning for these special populations. Next slide. The Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services, HHS, as part of 2 cooperative agreements. The content presented here is that of the authors and does not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. Next slide. There are no disclosures, financial or other, and no conflicts of interest for this session. You will find information later on in the presentation for those of you who are able to and wish to claim CE. Next slide. Here are today's objectives. They're lengthy, so I'm just going to let you look at them. Next slide. So you'll notice that we're going to cover the EMS, the ED and hospital, as well as the family perspective. And hopefully we'll have time for Q&A and discussion near the end. And then I would ask you all to please stay to complete the brief session evaluation. That information is helpful to us. And you are welcome to put questions throughout the presentation in the chat box, as well as the Q&A box, whichever you prefer. You're also able to use the chat box to introduce yourself and say where you're from if you like. Next slide. Here are today's presenters. I'm going to give you some information on who they are. Nick Saltzman has worked in EMS since 2005 and became a paramedic in 2008. He has a variety of pre-hospital experience, including urban, suburban, rural, transport, 911, and flight EMS. In 2018, he joined the STARS program at Cardinal Glennon Children's Hospital and has helped grow and develop the program since then. He is the coordinator for the STARS program, which has been implemented at 3 hospitals. In his spare time, he enjoys chess, hiking, and holding his breath for a Dallas Cowboys Super Bowl win. Dr. Roxana Lafort is an associate professor of clinical emergency medicine at Indiana University Riley Hospital for Children. She is the medical director of emergency preparedness for the hospital and the program director for the IU Disaster Medicine Fellowship. She leads the education work group for Region 5 for Kids, the Midwest Pediatric Disaster Center of Excellence, and works with PPN on disaster education for pediatric residents. Dr. Lafort is also the clinical advisor for Indiana's District 5 Healthcare Coalition. Kasha King is the Director of Leadership and Programs at Family Resource Navigators and a mother of 3, including a son with complex health needs. Drawing from both professional expertise and lived experience, Kasha has dedicated over 2 decades to advancing equity and access for children and youth with special healthcare needs. She specializes in emergency preparedness for families and caregivers with a focus on supporting underserved communities that often face barriers to essential resources. In 2024, she was featured in a national pediatric disaster preparedness campaign led by Texas A&M Emergency Services Training Institute. And her family story is a part of their curriculum on pediatric disaster preparedness, highlighting the importance of equity and family-centered approaches in emergency response. Darcel Jackson is the Manager of Patient and Family-Centered Care at Children's National Hospital, where she ensures the voices of patients, families, and staff meaningfully shape care, priorities, and culture. A recognized leader in family partnership, she leads initiatives that embed collaboration, transparency, and empathy into daily practice and organizational decision-making. With more than 18 years of experience in healthcare transformation and family caregiving, Darcel blends professional expertise with personal insight informed by her journey with her late daughter, Anaya. I hope I got that right. Darcel, you can correct me later when you present. Who lived with complex medical needs. Her leadership, grounded in dignity and shared decision-making, continues to elevate the role of families in creating systems where every voice is seen, heard, and valued. Next slide, please. Okay, I'd like to turn the presentation over to Nick Saltzman. Nick?
Thank you very much, Laura, and thank you everybody for giving me the opportunity to represent my EMS brethren. Next slide, please. So I just always like to start when I'm talking about EMS and children and youth with special healthcare needs and just framing the conversation a little bit and just highlighting that EMS is still a relatively new industry. Started in the 1960s and has really undergone significant change, especially in recent decades, as it makes that transition from how do we move people to how do we move people while rendering high-level, high-quality care. And because of those rapid changes, there's really significant disparities between how personnel are trained and different agencies and their capabilities, which is important to the conversation. Also, I can't help but note in that same time period, the pediatric population has undergone significant changes. There's been huge advances in medical care and this transition of having families go live at home or patients live at home with their families and communities. And all of that is awesome progress, but it has opened up some knowledge gaps and training deficits for EMS knowing what to do for all of the patients that live inside their community that they might respond to. And just to highlight that deficit a little bit, this picture on the right is actually my paramedic textbook from when I went through school, so about 2006. And that binder clip, that is the pediatric section. And of those pages, next slide, please. Only 4 out of 2,034 pages of this textbook were given to medical devices in kids. And so that left a huge gap, I should say, of information. And to make it slightly worse, special needs pediatrics was not a required part of the EMS training curriculum until about 2017, 2018. It was optional material until then. I don't want to shine too bright of a light on what happens in optional chapters in EMS education, but a lot of times those chapters are not well reached. And so fortunately, next slide, please. This is now required education, and this is just an example of the elements that are required in EMS primary education. But these are still really broad stroke descriptions of what an EMS provider needs to know. And I think you'll find that there's a lot of variety across the US as to what is taught in different paramedic programs. And therefore, there is kind of an opportunity where we need to really improve EMS education on what to do for some of our highest risk kids living in our communities. Next slide, please. And this applies not just to knowledge base for taking care of the kiddos, but also to response to disaster, right? That is still an incredibly localized and regional effort on what different EMS agencies and providers need to know. And so this is once again just that high level requirement, but there's a lot of details to be fleshed out there for knowing how to appropriately respond for disasters and for kids. Next slide, please. So I just like to point out that when you're asking EMS providers to be prepared to take care of children and youth with special healthcare needs, and you're asking them to prepare for a disaster, you're actually combining two low frequency, really high acuity elements that aren't always frequently trained on for them. And so I really want to kind of pull those elements together of how I think we can improve that. Next slide, please. One thing I like to highlight, and I'm not going to spend too much time on this because I have faith that these great speakers behind me are going to touch on a lot of these different elements. But for our families, especially our CMC families, every day it can be a bit of a disaster, right? It can be a challenge to navigate all the different challenges of everyday life. And sometimes we do need EMS to be involved. And my point for the EMS providers from that is that we actually can already be prepared for some of the emergencies, whether that's every day or things that come at us in a disaster, by focusing on how to get good at those CMC calls. Next slide, please. And so just kind of acknowledging the higher risk for our patients and how we can be available for them in the everyday emergency. Next slide, please. And I, once again, won't go through too many details because I'm sure you'll hear about more of these, but just I want to acknowledge that EMS often gets involved in several of these situations whenever the family, unfortunately, some layer of their safety net has been exposed, and sometimes they need that fallback of that community emergency resource to help support them and help them navigate the emergency. Next slide, please. And so I'm not going to read through the details on all the calls, but I'm just going to highlight a few elements of calls that are happening. And I'm of the belief that these 911 calls and emergencies for our families are happening each and every day around us, from our children's hospitals, in our communities. These kinds of calls are just happening with high frequency and regularity. And this is just an example of a mom she didn't want to use EMS. She was trying to take care of her kid and do all the care. But unfortunately, the emergency continued as she tried to self-transport, and she had to get EMS involved to help her navigate the emergency. So next slide. And that can include troubleshooting technology, which EMS might or might not have been well trained in, but this is just an example of an EMS crew showing up and helping do a trach change with home health nursing. So sometimes really trying to stack rare training with a really high acuity skill in the moment. Next slide, please. It can include trying to just support the family with basic logistical. So in this case, this family had the medication that they needed for the emergency. What they lacked were the medication administration supplies. And so they needed EMS to backfill with just syringes and needles in order for them to navigate that emergency. Next slide, please. And this final case is just an example of how hard it can be both for families and for EMS to safely transport. So going back to the heart of EMS, still we need to transport our patients while we provide high-level care. But just highlighting all of those elements as we do patient moves that need to be present with critical backup equipment. Anything that's power dependent needs its power cords and batteries. And all of the extra safe transport measures that we use for patient vital sign monitoring. So all of these elements are occurring in everyday emergencies, and then we have to also pull that into disaster situations. Next slide, please. So especially if I have anybody on here who does outreach education, you can attest to the fact that if you've met one EMS agency, you've met one. There's just such a variety to their different abilities and bandwidths. And that applies both to that everyday educational requirement. Some places will have, dedicated training officers and lots of education. Other agencies are struggling just to even get people to fill the seats, and they have outsourced their education to online or other sources. And the same applies for disaster as well. Some agencies have that ability and are already integrated into disaster response in their local community, and others are just trying to provide that 911 service. Next slide. So how do we pull this all together and kind of summit this mountain together? Next slide. So I asked two of the really high-speed EMS agencies that we work with, I mean, the kind that are preeminent and that you want your local EMS to be like. And so for Lee County, we asked them, so if you have a disaster and you have these kids at risk in your community, how are you going to prepare? And their answer quite simply was, we think the disaster pre-planning took care of that. We hope our families know which shelters to go to and that there's a plan in place. And then I asked, my other agency up here in St. Louis the same question, and they're like, well, whatever the county emergency plan tells us to do. And then we'll ask you guys for some extra information from the children's hospitals to help support our response from there. And, I think that's a little bit telling of EMS. Disaster is not usually their primary job. It's something that they get backfilled into. And then, they're hoping that other plans are taken care of. So next slide. So I do think that's an incredible validation of the EM work that's gone on. And so as far as making sure, okay, well, if they need to know everybody needs to be on the same page for disaster, let's all take the same coursework. That is not always required at all EMS agencies, but definitely have seen an improved uptake over time of everybody takes the basic FEMA incident command system. So the idea of, okay, other people have a plan and then we fill in with that plan. So incredibly important to make sure that your local EMS is trained in that and has a plan with their local emergency management for what to do. And then I think the element of bringing the children and youth with special healthcare needs in is just making sure that, okay, does that planning include them? Are we adequately able to take care of all of the patients in our community? Next slide, please. And so I think an important element of you, as you've heard me say, is just making sure our education is high level to address this, identifying at-risk patient populations that EMS might not be well prepared for, and training them so that they can take care of those patients, whether in an emergency or in a disaster, they have the knowledge base to appropriately treat. From the family perspective and preparation, I do think robust discharge planning can be incredibly helpful. And I mean thorough like resources, actually helping train, not just adding additional pages to the 500 sheets of paper I think we discharge you home with each and every time. But, providing some more robust, how are you going to interact with EMS? How do you identify your local EMS to know them? And a really important point of that, I think, is the ability to hopefully meet your EMS providers prior to an emergency. So the ability to reach out, call them, have them come visit you at your home or go visit them at the station and start to identify challenges or knowledge gaps that need to be addressed in a non-emergent setting. From EMS, I think a way to be very sensitive to this is to pay attention to the patients that our crews are responding to. And that comes down to, a more robust QA system and being aware of patients in our area and also reaching out to children's hospitals to get that feedback loop from them. And then also make sure you have a mechanism in place so that if a family calls your station, you know what to do. Oh, okay, we're going to arrange a home visit or we're going to introduce you to our medical officer or whatever that story might be. And then I think a way to improve education DMS from the hospital perspective is just to identify, through our discharge planning, where do we need to provide additional education to our EMS providers in the community? Next slide, please. So just some ways I think, especially from the high level, from the children's hospital perspective, how can we give more information to improve all this? We have access to vast amounts of information and knowing where, for instance, this is a map of our power dependent patients across our region, like these are the zip codes. We know that these patients have a critical power dependence. How can we relay that to crews and educate them and maybe improve their response for a disaster? Next slide, please. And another way, I think, not only training or not only education, but training, right? How do we improve the preparation? We want to make sure that we include these kiddos, our CMC kiddos, children and youth with special healthcare needs, in our tabletops and exercises. And so this is just an example of a local search and rescue team was going to do training. And they say we wanted PED specific. And so they brought a team out from the children's hospital to improve that training. Even just simple things as far as like, okay, let's add a power dependent patient with medical technology to the rubble pile, so that they had to think about, okay, how do we get out of this situation? How do we move this patient to an appropriate place? Next slide, please. And just an element that I briefly think I can add in there is thinking through not all tech dependence is the same when you're designing those tabletops and exercises, and thinking through different patients and how critical their needs are and how we can add those elements into those tabletops and exercises. Next slide, please. These next two slides are just examples of it, once again, using mapping to kind of identify patients at risk and how I think we can both prepare for that and then have better downstream response to our families. And so this is just an example of being able to search by zip code for power dependency and risk and be able to follow up with those patients after a disaster occurs to make sure that they're okay. And in this case, very fortunately, they were. And next slide, please. And then just the example of the same in St. Louis, the tornado that came through this year. So next slide, please. So just in conclusion, to pull that together, children and youth with special health care needs and children with medical complexity are really high risk in disasters, and they may require EMS support. And so how do we make that better? Improving the education, and improving their knowledge bases to help these kiddos on the everyday and in disasters, and then make sure that they're also are appropriately getting ensconced in the disaster response system. And so the only way to test all this, of course, is to do ongoing planning and training, and make sure that we are wrapping that all neatly together and hopefully advancing everybody. So to move on to the next slide, please. So that's where I'm going to pass it off to Dr. Roxana LaFord in Indiana for the ED and hospital perspective.
Thank you. Next slide, please. So I'm going to talk about emergency department and hospital disaster preparedness for children and youth special healthcare needs. And just to give you a little bit of a background of sort of where my perspective is coming from. So I'm a peds emergency medicine physician. So I work clinically in the emergency department at Riley Hospital, which is a quaternary care pediatric freestanding children's hospital. And previously I've worked in other pediatric hospitals, but always in sort of these big children's hospitals. And so it's a little bit different when we talk about planning for this population from the children's hospital perspective. And so hopefully what these next few slides will do is kind of help not just for children's hospitals, but for other hospitals also and other types of clinicians who care for children. Next slide. So just to recap, I just wanted to bring up a couple points that were really important from that previous the first fireside discussion that was a few weeks ago. Didn't want to repeat a lot of it, but just some points that I feel like are important to reiterate. One being that children and youth with special health care needs make up more of our pediatric population than most people realize. So the numbers do vary, but really probably about 20% of the pediatric population. So our children are about 25% of our population, and children and youth with special health care needs are probably about 20% of that. So that's larger than most people realize. And then another point that was brought up with that last fireside was that children are often not included in hospital emergency preparedness plans. This was a study that was released several years ago that kind of pointed that out. Next slide. And so with that, children and youth with special health care needs are included even more infrequently in plans, drills, and exercises. And I bring this to the forefront because I feel like sometimes with emergency management, the concern is that we're doing all this planning for, this very small population and, disasters and this small medically complex population. And they think that this is a lot of planning for something that probably will never happen. And that's just not true. I mean, one, this population, again, is kind of larger than we typically imagine, but also they are probably one of our most vulnerable populations, and any disaster is going to affect them in some way, shape, or form. And so as hospitals, we are often that lifeline for this population. And so it's critically important that we advocate for children and youth with special health care needs in all stages of emergency care and disaster preparedness. Next slide. And so I know that it can often seem overwhelming again with, with other emergency managers that are not in pediatric centers. And so I try to narrow this down for these next few slides into sort of three main points. And one being know your pediatric community and your patient population. Two, include children and youth special health care needs families and or providers in disaster planning discussions. And three, regardless of number one, so regardless of what your pediatric community looks like, plan and practice with children and youth special health care needs patient scenarios. And I'll get to why that's important later. Next slide. So know your community. Obviously, this is kind of step one in anything public health related, and emergency preparedness is public health. But it's really important to kind of have a good assessment of even just like the general pediatric population. So do you have large numbers of children? Do you have areas where large numbers of children are gathering? How many schools are in your community? Childcare facilities, are there zoos or children's museums or places where there might be large pediatric patients all together? And of course, this is important for any vulnerable population. So you would do this if you had a large memory care facility nearby your hospital. You would want to know about that and prepare for that type of situation. And so the same with pediatric patients. So really knowing what is in your community. I didn't know that there's apparently in rural Indiana, there's a large boarding school that people from all over the country send their children to. And so that's really important for those hospitals out there to be aware of, because obviously reunification would be an issue. These children are away from their parents. And so those plans are super important in that part of the community. Next slide. And so not just knowing your general pediatric population, but also knowing your medically complex population. Again, this is super dependent because the hospitals can be kind of the lifeline for this population. And so having an idea, as Nick kind of emphasized also, sort of where are your electrically dependent patients, how many event dependent patients are out there, but really involving your medical home providers, and they can really assist in gathering this information. And this is important too, because if you have patients that might typically travel to get to the children's hospital in a disaster, they may not be able to do that. And so they may show up at these smaller community hospitals. And so, and also the idea of if there's a surge and if the pediatric hospitals are full, if these patients are going to end up at these other hospitals for longer, it's really important to have a good idea of what else out there. And in some ways, these can be like, even at our children's hospitals, we get this information if there's patients that are on some very specific chemo medication or on an LVAD or a patient waiting for transplant that's very medically fragile. Having the hospitals really know that these patients are out there and kind of steps on what to do if they show up at your door. Next slide. So then that number one is knowing your community. Number two, including children and youth special healthcare needs families and our providers in disaster planning discussions. So this is incredibly important in these complex care pediatricians and primary care pediatricians. If you can get families, I feel like that's the best thing you can possibly have. But even just with what I do and in working with this population on a daily basis, discussions that I've had with families really open my eyes into the things that they are going through on a daily basis and the things that they consider, which is why these fireside chats I think are so great. But having even the pediatricians or the primary care docs or the medical home providers that manage these patients at the table, and they don't have to be at every emergency management meeting. But when you're starting to talk about your plans, writing out your plans, or talking about exercises or drills, places where they can add their input or add scenarios that you can include, or really add, the things that they are most worried about, can improve your plans significantly. Next slide. And then number three, as I said, regardless of what your community looks like, if you're in a small rural community and you have one small school and maybe one small daycare facility, or if you are like we are in an urban center where we manage most of the medically complex patients in the state, regardless, plan and practice with children and youth with special healthcare need patient scenarios when you're doing disaster planning. And the idea from this is really that if you plan and practice for the most complex patients, this is going to improve preparedness at all levels for all patients. Kind of that idea of you take the hardest, practice with the hardest questions and the hardest scenarios, and those easier questions are going to go more smoothly. Everybody's going to be all aspects of disaster planning will be improved if you include these complex patients in there. I love adding true story patient examples. Again, you can get these from patient families or from the providers, but really getting these true stories into these scenarios and into your drills and your exercises can really open the eyes to people of the running through them, and nobody can say that this would never happen because it's an actual story. And making sure that it's included in all phases of disaster. So I know emergency managers are great at thinking about communication and reunification, but also adding for the clinical providers, adding it into the clinical care aspect of drills and exercises. Next slide. So that's kind of what I have. Really, just in conclusion, those three main points. It's at least a starting point to improving disaster preparedness for this community. One, knowing your pediatric community and patient population, including these families and/or the providers that care for these families in your disaster planning discussions, and then practicing with children who use special healthcare need patient scenarios. Next slide. And so I just wanted to give a couple little examples on how we do this or how we add this patient population into our disaster planning. And I just kind of wanted to talk about a drill that we did. It was really more of an exercise we did with our emergency medicine residents several months ago, where we kind of walked through a cybersecurity attack and had them practice a downtime event where EHR and communication resources were all down. We had them walk through, getting up their whiteboard and their paper charts and sort of walking through that whole sort of disaster scenario. Next slide. And then we tried to add just some medical complexity with a pediatric patient in there. We had a 10-year-old female that showed up with insulin-dependent diabetes and presents with vomiting, and had them kind of consider the medication and the history and how they're going to get that history when the parent's not with them, and how they're going to write for the insulin drip with the pharmacist when they don't have their typical setup. Next slide. And then we had a 6-year-old with a bleeding disorder who presents with a fall in the playground at school and altered mental status. And the idea was he was supposed to get factor, and having them kind of go through that process of identifying that when they don't have the family member with them and they aren't able to look through that medical history. Next slide. We have several other examples. Again, I'll share these slides so you can look at them later, but sort of the viral respiratory surge, we did this at the district level. We have lots of patients that present with bronchiolitis, infants with bronchiolitis, and then we have some that have chronic lung disease or cardiac defects, and kind of deciding on who gets transferred to the pediatric center. And then with our peds residents, we do an ice storm scenario where they're having to decide kind of who they discharge before the storm to make room for those potentially medically complex patients that are coming in and who needs to stay. And then evacuation is another one that we talk about and make sure we add these complex patients into those scenarios. Next slide. And that's all I have. I'm going to hand it over to Kashaw and Darcel for the family perspective.
Thank you, Roxana. Good morning, everyone. My name is Kashaw King. Next slide, sorry. There we go. This is my guy, my son, Christian. Christian is now 28 years old. He is nonverbal and non-ambulatory. And so I'm going to just talk a little bit today about Nick and Laura have done a great job of really talking about the importance of the family perspective when we're planning for disaster preparedness. So I'll talk a little bit about kind of our experience, my experience with other families. He is my why. He is why I do what I do, and the important points I bring up about why it's important for us to be able to work with, the healthcare system to ensure that during disasters, we can best meet their needs. It's not going to be perfect. And, we have, I think, I really want to say that I don't think people thought our kids were going to live this long. And so preparation for treating children with complex health needs during a disaster has just come to the forefront. And so it's important to really highlight the intense needs that are needed when we're looking at disaster preparedness. So many of us, our families, are on a daily basis, we're prepared, right? We have our emergency visits. Unfortunately, that is a part of our daily lives. But that versus a disaster emergency is a whole, it looks very, very different. So it's a whole different level for us in preparing for that. And many families, they don't have the means to honestly to prepare, or they don't have the resources to prepare. And so for me, my thinking was I actually approached our physician, my son's physician, and I said, we need to get a plan in place. I did not want to be caught off guard in the event that a disaster happened. Because there is the possibility, and this is a reality, that if there is a disaster, my son could get separated from me. That would be devastating. Um, and when we're thinking about preparing for our children, um, it feels like the unthinkable. How do I keep my child alive when everything around us stops working? Laura just talked about, you know, power. Nick talked about, equipment. In situations where families call EMS, and how do we look at treating them continuously, because it's important to try to keep children keep that consistency with them. They're like with my son, and other children with complex health needs, ventilators are involved, oxygen concentrators, feeding pumps, suction machines, monitors, all of this power that they need, stable power in order for them to continue to live. I mean, that's the reality. These are real lives, and it's important that they not be an afterthought. And so we're thinking as a family, like, how many hours of battery do we have left? Are there healthcare community members who are helping us to think about all of these things? Because on a daily, although we as parents are acting like doctors and nurses and caretakers, at the end of the day, we're parents. And so there's so much on a daily that we're making sure that our child, lives and makes it to the next day, and all of the other things that goes on. There are things that are going to slip our minds. So it's important for us to have those partnerships with the healthcare community, community places like churches, shelters, going to talk to shelters. I've gone around my area and I'm like, okay, or would you be prepared for a child like mine's who needs equipment essentially to live? Will you be able to treat them? Talking to them about what the needs are. Going to the church. I've done a presentation at our local church and said, have you thought about these things, in case of an emergency? Are you prepared for people who may not be able to necessarily take care of themselves? And then, as you know, fear shapes everything. So in those times, everyone is panicked. And although hospitals are a safe backup plan, um, because that's exactly what they are. During a disaster, hospital staff are also overwhelmed, and the system is fragile too. Um, and Nick touched on this. About, emergency personnel understanding like a child's baseline, and whether or not first responders are comfortable with children with ventilators or trachs. And then, most importantly, families that fear of being separated from your child and if your child will be taken care of in your absence. And I don't think that people really think about that. It wasn't one of the things I thought about initially, but I then had to say, what would happen if my son were separated from me? If Christian was separated from me, what would that look like for him? So I had to make sure, um, you know, my local fire department knows about him. We even have the local hospital that we're not a part of, but I even went there because he did have a visit there, and and we are fortunate that we live near a hospital. So we're on the hospital's grade, the power grid. And so we're lucky, but not every family is lucky in that way. And when I started his emergency plan, initially I had this big binder. And then one time we had a emergency visit, and it was a really, really bad emergency visit. Like, we literally, because the EMS was taking so long to come, we drove him to the hospital. Um, and at that time, there were a ton of questions being asked of us, and we're worried about him. And we know that the hospital was just doing their job. But it made me think, what's an easier way um, that I could have something that tells them about him and his needs, but I could still be attentive and be able to help the staff who was or the emergency personnel who was aiding him, and still be able to be present in that moment. So I began to, I got him an iPad and I have all of his information on there. And so the next times because that's often we're in the hospital. I handed over the iPad to them, and I'm like, here, all the information you need is here. If there are other questions that are not like right now questions, um, I can answer those later, but I really wanted to make sure that I could be present with my son while also making sure that they have what they need in order to treat him. And I know that every family isn't able to do that, but I think it's important that we have some sort of go-to during those times. So imagine in a disaster, if there's a disaster, what does that look like? The what ifs. And, when we think about um, what that's going to look like, yes, most families know about an emergency plan. They know about emergency go bag. I have all of those things. I even, like I said, go my local area, all of um, anybody I could think of, the shelters, the churches, and the fire department. But I also, all of my neighbors around me know about my son. I've created signs where when emergency personnel comes around in case of an emergency, there is a sign in all of my windows in my home that says someone here has a complex health needs and needs to be aided to immediately. It's a priority. And so a phone tree that we've developed. So all of my neighbors, and they also all have a summary of what his needs are. If there was, a time when we're stuck here in the home and can't get out, my neighbors know to come over and check on us. They know what his needs are. If they're able to aid us, they are all prepared to do that. And so, when we look at how do we educate our healthcare system to think beyond, just the everydays, right? We really need to think about what does that actually look like for families? What's the impact? Because the impact on children like Christian, that impact is an impact on the world and on society, because there's so many more of Christians living in this world. And as I stated before, they're living longer lives. And it's important that um, the community come together and really think about that. And so, although there are some healthcare systems that are thinking about this, looking at that, a lot are not. And so a lot of times the burden falls on the family. Um, and we know that it's going to take time to do that, but on a daily, I think that families don't necessarily think about these things. So I work with families of children with disabilities in my work. And I have developed what's these they're called learning. I've created these learning groups where I invite parents to come and uh, do an emergency plan for their child. Think about all of the things. Give them, a list of these are the things that you should be looking at when you're preparing for an emergency. And share resources with them. These are the things you need to do in your community, your area. And so with that, I know that I'm still on my first slide, but I just have photos of my son. You can go to the next slide. Just highlighting Christian and these, equipment and, hospital stays. This is what life is like for us. And I will, the next slide, please. And lastly, I would just say emergency preparedness is a shared responsibility. This is where the strength of families, community partners, physicians, hospitals plan together to ensure that children and youth with special healthcare needs receive the care, attention, and support they need in times of crisis. So I will end there and I will pass it to Darcel.
Thank you, Kasha. I think a lot of what you shared mirrors a lot of what our experience is. And so to not duplicate, I think I'm going to reframe it a little bit differently. We've all experienced COVID, and so we've all kind of lived through a pandemic. And personally, I've had experience with snowstorms and lower category hurricanes and minor earthquakes. And truthfully, the honest everyday emergencies of caring with a child with medical complexity. But when I think most often of preparedness, honestly, is when I watch movies. As a parent of a child with medical complexity, preparedness lived in the back of my mind every time I watched a movie because I likely did not watch them the same way other people do. When you see these movies, you see all the running and the panic and the shouting, and I always find myself thinking, what would I do in that situation? When we think of like movies like Independence Day, now I know it's not real and like that alien thing may not happen, but you see images of people jumping out of cars and sprinting through the streets. You also see that in films about wildfires or tsunamis and hurricanes, even active shooters, where you see teachers hustling entire classrooms onto school buses or under desks for safety, or EMS ushering families out of their home. Even I seen a movie a couple of weeks ago where EMS was ushering families out of their cars and jumping into a lake and all diving under the water from flames that were jumping overhead. But the truth is, those were rooted in reality. And honestly, every single time I had the same thought. There's so much of that that we could not have done. Can we go to, the next slide and go to the slide after that? This is my daughter Anaya. Before her passing, she was 5'5", 130 pounds, non-ambulatory, medically fragile, and technology dependent. So when I seen those scenes, whether she was an infant or when she was 18, my mind never goes to escape. It goes straight to logistics. Would the bus that the teachers were trying to get her on even have a wheelchair lift? Likely not in the emergency situation. So if it didn't, who was going to lift her? Were they going to be able to do it safely? Were they going to be able to secure her in the seat because she needed an adult-sized car seat if she was not in her wheelchair? She was on continuous feed. She needed meds through her GJ tube every 3 hours, breathing treatment, suctioning, monitoring. Would any of those things make it with her? If they did, would the battery last? Would there be power wherever she ended up? How would we be reunified? That's exactly what Kasha was stating. And while others may see a movie, I see equipment, timing, and uncertainty. And that's why for families like ours, preparedness is not simple. Likely, we're going to have to stay. We're going to have to shelter in place and hope that the systems around us don't fail. And so the question that always lived with me was, I would have stayed because I'm her mother, but with others? Can we go to the next slide? If she was at school, if she was at a hospital with responders, would they have tried to take her with all her special needs? I don't know. Would someone stay with her if everyone else was leaving? I don't know the answer to that either. Would they know what to do if they did take her? Could they keep her safe? Those are the questions that really are at the heart of disasters for me and families like mine. And it's really rooted in the fact that the answers cannot depend on whether the parents or guardians are standing in the room. Because real life, it's going to happen. And earthquakes are going to cut out communication. Snowstorms are going to shut down heat. Hurricanes, tornadoes, they're going to destroy neighborhoods. And COVID, it really showed us all how, as humans, we're fragile, but also how fragile our supply chains were. So imagine families like mine may not just also be taking care of the one child with medical complexity. For 3 years, I was also the guardian of my nephew Quincy, who has autism. And so for him, the disaster wasn't always the event. Sometimes the alarm was the disaster, right? It was that fire drill at school, the ambulance siren. He would shut down, put his hands over his ears, overwhelmed by the sensory overload. And meanwhile, my bonus son Byron was growing up in the middle of all this and navigating his own fears, his own routines, wanting to help, wanting normalcy, wanting reassurance. Can we go to the next slide? And so preparedness in my home was never a single plan. It was three very different plans woven together: medical, sensory, emotional. And that required a whole lot of coordination because the plan had to fit the child and the entire family, not the other way around. And this is important because we have to recognize that not all families can run. Not all children can be moved quickly. Not all children can tolerate the chaos, the alarms, the crowds, the bright lights, the unpredictability. And preparedness really starts with acknowledging all of those truths. Can we go to the next slide? And so a lot of what it takes to build these systems that protect children with special healthcare needs and medical complexity and neurodivergent children at home, at school, and hospitals, and with EMS were already shared by my colleagues. However, I'm going to frame it in a way that for me, where how we navigated our home with these three essential things that every family needs, no matter where they are, when emergency or disaster hits. It's where power, paper, and people. So for medically complex children, electricity is not convenience, it is life support. There's ventilators, feeding pumps, oxygen concentrated, refrigerated medications. None of these things pause for emergencies. So we need these practical things like backup batteries, generator access, to be on the medical priority utility list. And paper is going to save us. It's going to carry the plan when technology fails. We created a simple portable medical summary for my daughter that could save her life if she was not in our presence. I had a copy with me, my husband had a copy with her, and she had a copy with her in her bag that went with her everywhere. This had the basics: her diagnosis, her medications, her baseline, her device settings. And even for Quincy, who was neurodivergent, he had one too that had what calmed him down, what triggered him, how he communicates. Because sometimes that one thing of paper is going to be the thing that stands between confusion and continuity for our babies. And I think when we talk about people, we have to never forget that caregivers know their children best. We know the early signs of distress, the sensory needs, the routines. We need to be part of the planning. That's the only way that preparedness for families are going to work, when we're treated as a part of the team. And I would be remiss if I don't call out here that all families don't have access to the same amount of resources. There are families that have limited financial resources, limited transportation, and that can carry a heavier burden. And all of those essentials are going to show up at home, school, hospitals, and with EMS. And so I'm going to hit a couple things that weren't discussed for preparedness. Is that we often say in our kind of emergency preparedness kits that we want families to have 72-hour supplies. But we need to make sure that's something that can happen, because insurance, it doesn't always make that easy. You know, one example is my child was continuously fed through her G tube and her pump, but her bags required the pump. She didn't have a gravity fed bag, but insurance wasn't going to cover it because they only supplied us with 30 bags per month that worked with our machine. So if we exhaust those 30 bags and there's a supply chain issue, there's an issue on how we're going to feed her. So we need to really navigate all of these things as we're discussing the plan and really making sure we're exposing the gaps and we're working together to coordinate it. I think the other thing that I'm going to make sure that we mention, that I know was mentioned before, is there is a difference for families between routine emergencies and disasters. And so we know that in routine emergencies, we can assume that help's going to come quickly, but we have to assume in disasters they may not. So we really need two separate plans for families: an emergency plan for everyday event and then a disaster plan that provides that longer term way to navigate power loss, the block roads, supply chain failure, etc. And so in closing, we can go to the next slide. I think that preparedness, when it's done well, is going to mean every medically complex child has a standard emergency form, both paper and digitally. Every neurodivergent child has a sensory and communication plan included, that every hospital has a pediatric disaster annex that protects family presence. One of the biggest worries I've always had was that in a real disaster, my child may not be able to be transported to the pediatric hospital that knows her and knows her well. If she was going to an adult hospital, would they know how to care for her? Would they have the equipment to care for her? So we need to plan for that. And we need to ensure that every caregiver is treated as an indispensable member of the response team. And so I'll close it with really one sentence before we hopefully have a couple times for comments and Q&A, is that when I watched those movies, one of the things that I think was really helpful for my heart and humanity is that there was always that one person that turned around back for the person who was left behind. I don't know if that's rooted in reality, but what I know we can do is what we're doing now, is we're having the conversations about preparedness so that as a community, we're choosing to not turn back, and we're making sure that we're preparing on the front end to make sure that no one is left behind. And then I guess we can look at if we have time, Laura, I'm not sure for any questions and comments in the chat.
There was discussion back and forth, which I really greatly appreciated. So thank you. Go to the next slide, please. I just want to thank you, Darcel, as well as all of the presenters for bringing your perspective to this particular table. This is a critically important topic, and thank you to all of you and to everyone else who attended today for everything you do now and on a day-to-day basis for kids. I put information on how to collect CE or request CE in the chat. I also put the link to the evaluation of the session. So you can use the QR code on the next slide, or the link in the chat. And then I wanted to ask first if any of the panelists had questions or final words that they wanted to share. I do not see any takers. Are there questions that people wanted to ask of the presenters? Jonathan, you can go ahead and unmute. We have 3 minutes.
Can you guys hear me?
We can.
Great, thanks. Thank you all very much for this conversation. I have to say, especially to the parents who spoke, Kasia and Darcel, and I apologize if I pronounce your names wrong. Everything you said is amazing, amazing, amazing. I mean, you can see my fingers were flying in the chat here. I guess I want to ask this group just sort of live, if you would, why aren't we having more specific conversations? I mean, again, I think it's a wonderful thing to be able to say, this is what an institution has done. This is what we did. Let's pat ourselves on the back for our efforts. But Darcel, you in particular laid out so cogently the gaps that remain. And you were very specific about what those concerns are, what those needs are, how much work each of you parents are doing for your kids, for your families, and you are not alone in doing that. Why are we still skirting over the top and having these superficial conversations around, wouldn't it be lovely if everybody got together and sang Kumbaya, and meanwhile you guys are going back and having to do all of this work to take care of your children? So can we get more specific? Can we get deeper and actually talk about how we're going to solve the problems for real? Because clearly the gaps remain. So what do we need to do as a community to get this into the details and actually solve your problems?
I think, I don't want to speak for Kasia, but I think what she shared and what I shared, and I think why we are honest is because I think for too often we are rooted in fear of the conversation of what life is really like. Recognizing that we don't have all the answers. And so some of that is because we don't know what to say and we don't have all the answers and response. We kind of avoid the conversations, but we're not going to ever get to a real response if we're not having the real deal conversation about what the fears are, where the gaps are, what we do well, what we don't do well. And I mean, I think the real conversations are going to be the only way to get there. But I think we have to overcome the fear of having those difficult conversations.
I will agree. And I think part of the fear is that, are the institutions ready to have these conversations? Because again, as you can see, as families are doing all the work. We're bringing this to the forefront. There are healthcare systems who are also doing it, but it's really on the surface. And so, Jonathan, thank you for your comment about that, because I think that is important that we look at the real work, what real work can be done rather than continuously talking about what needs to be done. We need to really, there needs to be action. We're beyond that at this point, and there are real disasters happening out there, and our children will be the ones who suffer the most.
Thank you. Any comments from folks that I know have experience in this area? I see Dr. Dahlgrove and Dr. Sarita Chung as part of this group. If either one of you want to come off mute and share a question or make a comment, you are welcome to. Or members of the C2TF, which is the task force that oversees this topic for PPN. Well, we're at the top of the hour, so I'm just going to say thank you again to everyone. We will share resources and the link to the recording and the slides with you. And we hope that you're all inspired by this conversation to do something impactful, and have a great day.